And in common, the prostheses do not have a sensory feedback. However, there are advances in this. Recently, bioprosthesis was implanted in the Rehabilitation Institute of Chicago in the United States, which had a sensory perception ability. Why is sensory perception important? It is important in the upper limb during grasp. Otherwise, the person will not be knowing how much power he is putting into the grasp while lifting objects. For example, he may end up crushing a tomato. There is a difference between lifting a tomato or lifting a toolbox. So that is where the sensory perception in the upper limb process plays an important role. But however, till date, it is not commonly used, and that is where commonly the upper limb process is usually rejected also, because it does not usually serve the purpose of the patient. There are different types of upper limb prosthesis. The commonly used is a body covered prosthesis. The body covered meaning you use the power of the existing residual limb, that is the shoulder and the scapular, protractors, retractors, abductors, adductors, in order to move the prosthetic joints. That is the prosthetic elbow joint, the prosthetic either the hand, the prosthetic hand, which is known as the voluntary opening or the voluntary closing type. So we use the body power. That is the meaning of using the terminology body power. And the other is the external power, in which we use something like a battery, which will move the wrist or the hand. And the third type is the cosmetic or the passive process, which is only replaces the cosmetic appearance of the hand. This is commonly used in the form of, usually in the hand amputations, wherein the patients will usually come and ask for a cosmetic glove or even a cosmetic finger when the finger is amputated. There are different parts of the upper limb prosthesis. These are the terminal devices. The terminal devices meaning the hand. This can be either a cosmetic hand, a functional hand, which can be voluntary opening or voluntary closing type, or a hook. The hook is also commonly used, even though it looks cosmetically very inappropriate. It has very good functional ability, and therefore, especially in villages, they are more comfortable using the hook. Then there are several other modifications in terminal devices depending upon the profession of the person. There are prosthetic end devices, terminal devices for a person to allow him to even swim, or to allow him to play golf, to allow him to play tennis, or even to allow him to reap a harvest. There are different modifications. Then the next part is the wrist joint. Then comes the elbow, which is it can be. Then comes the shoulder joint, then the socket, and the suspension. This is the mechanical hand. This is what I was talking about, the functional mechanical hand. This can be either voluntary opening or a voluntary closing. And usually it is the voluntary opening type which is commonly used. That is the closing aspect, which means voluntarily either close or you voluntarily open the cosmetic hand, the functional hand. And this is the hook, which is another form of terminal device. And this is what I was talking about, the cosmetic glove. This can be colored according to the skin of the patient. The more commonly used is the lower limb prosthesis, because the success rate and the compliance rate is higher in lower limb prosthesis, because it serves most of the function of the patient. The different prosthetic components are the foot angle, the shin piece or the shank, the knee joint, the hip joint, the socket, and the suspension. This is what sir was asking about, the patellar tendon bearing orthosis. And this is the same thing we use also in prosthesis. This is the socket. The socket is, in order to make the socket, we first take the cast, that is the POP is applied. That forms the negative mold. And then over it inside we make a plastic mold. Then after we take the mold of the residual limb, we have to give relief areas and unrelief areas. That is, we give relief areas over the point where pressure is not tolerated, so that pressure is not loaded over those sensitive areas. So it is important that when a socket is delivered to the patient, you check these areas so that it does not lead to any complication at a later date. So these are the pressure tolerant areas, which means the weight can be put on these areas. That is, relief need not be given inside the socket. So these are the femoral condyles, the medial tibial flare, the tibial shaft and anterior compartment from the posterior compartment. And these are the pressure sensitive areas, which means you should not put pressure on these areas because they are very sensitive. And naturally it is the lateral aspect of that is the fibula, because the peroneal nerve is there. Then the tibial crest, because it is very painful, and also the hamstring tendons, because it affects the gait. these are the two types of again transtibial prosthesis. To the left you see the older type, which is made of wood, and it is called as the exoskeleton type of prosthesis. And to the right is a more advanced endoskeleton type of prosthesis. The endoskeleton is not delivered like this; it is shown to you, and over that endoskeleton part we give a cosmetic cover so that it does not. There are different types of suspension, and these are of less importance. There are ring suspension. The commonly used is the cuff suspension. It is fabricated from background and lined with leather. It encircles the thigh and encircles over femoral condyles in the proximal part of the patella. The attachment points on the socket are slightly posterior to the sagittal midline in order to resist hyperextension forces at the knee and to allow the limb to withdraw slightly from the socket during the knee flexion. This is the another type of socket. In this there is no suspension, there is no external suspension material is used. The socket itself fabricated in such a way so that it holds on to the residual limb. This is called the supracondylar type of suspension. And we have supracondylar and also suprapatellar type of suspension. This is known as PTS type of socket. The expansion for it being prosthesis tibial supracondylar. It is a French name. And when we go to the above knee socket, there are commonly two types of sockets are found. These are the quadrilateral socket, which is the most commonly used, but the more anatomically right but requiring much more expertise is this socket, which is the more advanced type of socket, that is a contoured, adducted, trochanteric controlled alignment method socket. You can see in the right picture the difference between the two types of sockets. You can see that the one with horizontal, more horizontal than anterior-posterior dimension is the horizontal type of socket, that is the quadrilateral socket. And the other over and above which is drawn is the ischial containment socket. So it is more mediolaterally the dimensions are more and anteroposterior dimensions are more. The mediolateral dimensions are less. So what is the advantage of this ischial containing socket? You can see in the left of the picture, it provides a bony lock and it places the femur in the proper anatomical position. That is, the pressure along the shaft of the femur is given so that it is kept in an adducted posture. That is why it is called a contoured, adducted, trochanteric controlled alignment method of socket. Then there are different types of knee joints depending upon how much you can pay out of your pocket. These are single axis knee joint, polycentric knee joint, and the more advanced microprocessor controlled knee joints like C knee, C legs, which is made by the Autobot. This is the simple single axis knee joint. A little bit of friction can be controlled in this, but other than that, nothing else. It serves the purpose. This is a polycentric type of knee joint. It is commonly indicated in a patient in a through knee disarticulation and long residual knee, in which long residual limb, that is in a. Then there are different types of ankle foot prosthetic feet. This may be the solid ankle cushion heel type for the single axis foot, the biaxial foot, and the stationary ankle flexible endoskeleton. And also there are dynamic response feet. These are used in sport persons, and probably he will run faster than the normal person because of the dynamic response feet. And this is just to show you the commonly used and more very famous Jaipur foot. And the Jaipur foot consists of 3 structural blocks simulating the anatomy of a normal foot. The forefoot and the heel blocks are made of sponge rubber. You can see the forefoot and the heel blocks. These are made of rubber, but the rubber layers are of multiple layers and of different densities. This will simulate in order to, during the loading response, in order to simulate the plantar friction, this aids. And the ankle part is made of light wood, and this is fixed using a bolt, and the entire structure is covered using a vulcanized rubber, and the whole system is then put inside an autoclave, heated, and forms a permanent rubber kind of component. And after all this advances, some people are just happy to go along with this what is known as stubbies in a case of bilateral AK amputation. However, it is not cosmetic, but some patients do prefer. We have follow-ups of patients who come back and still they don't accept an above knee prosthesis because of excessive energy consumption. They feel that this is easier for them to work.
Thank you. Sir, what is pylon?
pylon is just any metallic kind of material which can be used. It is commonly used in immediate post-operative amputation cases, so that we can start amputating the patient on the second or the third day. The advantages of using a pylon, people say, was that it helps in when you load the residual limb immediately, it helps in lesser amount of edema, it helps in maturation of the residual limb. So that is it is a temporary, it is a temporary process given immediately post-operative.
What are the essential difference between Sag foot and Jaipur foot? Can you think?
Essential difference for the thing is this. This is cosmetic. The Jaipur foot. The Sag foot is not cosmetic. The forefoot and the heel are in the same level, the same plane in a Jaipur foot, so that the barefoot walking is allowed in a Jaipur foot. Whereas in a Sag foot, the forefoot and the high foot, there is a minimal height difference. That is, it will simulate something like a plantar flexion. So the patient has to always wear a heel shoe when you use a Sag foot.
And inversion at the foot so that sit cross-leg. Is there any difference like that?
There are modifications, many modifications which can prevent rotation at just above the joint. These have been tried at above elbow prosthesis also in order to prevent internal external rotation, and also just above the knee in order to prevent rotation, and also at the hip joint.
In between these two foots, is there any difference of internal rotation so that patient can sit cross-leg in Jaipur foot or cannot sit cross-leg in Sag foot? Like
The
this?
foot part doesn't make any difference.
No difference.
So how does dorsiflexion and this inversion take place in Jaipur foot?
Yeah, a little bit is there.
Inversion is not less, but the dorsiflexion will not occur. That's what I was saying. There are multiple layers of rubber, and when you load at that point, during the loading response, the initial contact following the second phase of the basically have the loading response. During the loading response, the rubber compresses a little, allows for compression. This happens even in the Sag foot and also in the Jaipur foot, and that simulates plantar flexion. That's it. It allows very minimal motion. It does not. If you want more mobility, then we have to use an articulated type of
So
foot.
then how this patient
It
gets
does
square?
not. No, it
The
cannot.
Jaipur foot patient gets square. How does this take place?
What's the one?
Squatting in Jaipur foot. Whether the patient has squatting in Jaipur foot or not.
Oh, squatting.
Yeah.
It's fine.
Squatting is
Yes, there is.
they can do,
Middle
but
part is made up of such a rubber that dorsiflexion is possible there.
dorsiflexion is possible.
It's not
That
that
way
much
it is
possible
done
to
that
allow
much.
proper
It's
standard.
not squatting. It's not that much dorsiflexion is not there.
Squatting and cross-leg.
Cross-leg there.
Cross-leg.
Cross-leg is not. Cross-leg is not.
Sir, there is
What's the difference between a Jaipur foot and a Madras foot?
what?
Decision taking regarding level of amputation in different conditions mostly we encounter. That if you can explain a little bit at what level if this kind of patient is there, this is the possibility, at what level we should prefer. Because whatever you think, one should know the level.
Is the level consideration is there?
With the latest prosthesis, there is no consideration.
No consideration.
Nothing is there at any
Want to
level.
say that you want to
Now please just take the
phantom limb, anything you want to can be prevented or
There is nothing to prevent. They say the pain has to be controlled during the post-operative phase in order to prevent the phantom pain, but it is not proven. And the phantom sensation and the phantom pain, I can first go for any medications, or you can use cognitive behavioral therapies, counseling, and recently they have used even mirror box techniques in order to prevent the perception of the phantom.
Okay, so now let us start our process portion. Now one by one. Yes, better. Now focus.
static type of wrist hand orthosis. This is the forearm part and then the hand part. It is placed in position by using the straps, and you can see that the thumb part is a little placed in wider in order to prevent the web space contracture. And there is a small amount of angulation, that is around 10 degrees of
Hold the mic.
extension.
Mic, hold. Will hold. Yes, keep both hands free. Better, yeah.
Hand piece and the forearm piece. This is the dorsal type of splint. Volar. This is a volar type of splint, which means it is placed like this. And the problem in this splint is it totally prevents the function of the hand. And therefore, in order to improve the function of the hand, the volar placed splint is used, in which it comes anteriorly.
This is similar.
Again, this is a similar type
This
of
is similar.
orthosis. These are all types of static orthosis. We have a different classification of orthosis. We have static progressive, and the dynamic type of orthosis. Static orthosis, in which the hand aspect and the forearm aspect, they are rigid, and this cannot be moved. And in a static progressive type of orthosis, we have a turnbuckle type of system between the hand aspect and the forearm aspect, which can control the angle, that is the wrist extension. It can be used, for example, in a case of Volksmann ischemic contracture-like condition, or it's also used in a flexion deformity of the knee or in a flexion deformity of the elbow. Then we have the dynamic type of orthosis. I think you could have seen the pictures of it during the presentation, which is used in a condition like nerve palsy. It assists extension, finger extension, and wrist extension.
In this, you can see one, not only this thing, but here we have two bars on the sides of the finger area. These are to prevent any deviation towards the ulnar or lateral, medial or lateral side. This is in case of Hansen's disease. We usually give on the lateral side to prevent lateral deviation of this thing. And also in cases of rheumatoid arthritis, we give these type of splints with these bars to prevent the deviation of the hand.
In dynamic of the splint, where the strap should be there, either distal DIP joint, PIP joint, or MCP joint.
That is according to the need.
Read
From
in
where? Yeah.
Suppose we are giving for wrist draw.
Yeah.
Where the strap should be? Should we keep it here, the DIP joint, PIP joint, or near the MCP joint?
Extension assist.
Okay.
Basically, we are giving for the wrist drop only.
Okay. You are the splint will come to this part only.
Yes.
Yeah. So that we can move there is no limitation of movement in the MCP joint, and it will be on the dorsal aspects and the fingers. We can move the fingers. That is the out fingers. I have shown the figure. I think in the picture I have shown the picture, and it will be given in the near the in the PIP joint. Out triggers.
Near PIP or near the MCP joint? Near MCP. Because we have intact lumbaricals in they will automatically cause an extension of DIP and IP joints. So limitation here, what we have is extension of the MCP joint.
Yeah.
So if you give near
the extension at the MP joint. No?
Yes. If you give near to the MP joint, the leverage will be less. So near the PIP joint, but in the phalanx, near the PIP joint, the leverage will be.
Basically, it should be in proximal phalanx.
Yeah. But little bit.
It should be in the
Give
proximal
the
phalanx.
leverage give the leverage.
If you give it near the MCP joint, the leverage will be less.
So just remember, it should not be given in the distal or middle phalanx. It should be given in the proximal phalanx. Okay.
And this is knuckle bender splint. This is broken. Yeah.
While after tendon repair, nerve repair, what will be best like the dynamic or static?
Tendon repair. You Immediate tendon repair, after tendon repair, it should be a static one.
We use
It
a
should
static block,
static.
block type of.
Block type of thing.
It has to block the range of motion which you do not want to.
This is knuckle bender splint. Knuckle bender splint, and here there is it is not there, but there is a rubber band connecting these two parts, which keeps the MCP joints in flex position. In case of ulnar palsy claw hand, we give this one. Upper limb curve.
The different parts of it and how to don it.
Yeah. Here you can just this roll is to be in the front, and
Why not the other way?
other way means yes, same. But here there is another extension is there. This extension is there with C bar. You know? This extension is there.
What are the parts, sir?
पार्ट्स क्या है पार्ट्स का नाम है नाम तो नहीं पता नाम होता नहीं नहीं ऐसा पार्ट्स बोल के नेम नहीं
Is it site specific?
नहीं
Both can be
both can be yes
In upper one is just you can know this presence of this thing with the hinge and static
So
presence.
median now what we use?
के
Should we
लिए
do?
Specification.
Now you can go with
Cutter
the
splint or
certain
something is there?
No, not gutter splint is
lower
used for the
limb,
lower
lower
limb.
lower limb
Gutter splint is used in order to stabilize
So
the
here we can see this.
gutter जैसा होता है.
This is important.
It is used sometimes in order to teach gait training during cerebral palsy.
Focusing on the CTV. And foot drop. Foot of CTV screen, this will be.
Yeah.
And of course here.
And FR.
FR is this is CTV shoe basically CTV boot but this is not properly done although it is like that. So here in CTV boot what happens, there is the medial border is straight, there is no curve in the curvature in the medial border is straight and there is no heel, but in this boot there is a heel. What this heel is, this heel is CNE heel, crooked and elongated heel. And if you, whenever a boot is given or shoe is given to you, you first see from what side, for what side it is. It is left or right. This is right. This is right, and then you go see the medial border. Medial border is straight. That means it is a CTV boot, and there will be no heel. In case of a CTV heel, there will be no heel. But if it is given, it is elongated on the lateral side, then it is CNE heel. But if it is reversed, that is this elongated portion is on the medial side, then it is reverse CNE heel. The CNE heel and Thomas heel the same. Yes, CTV boot sometimes it is given. Usually in CTV boot there is no heel. The height of the forefoot and the hind foot is same. It should be same, because we are correcting the equinus. If you give a heel, then it will be of no use. It will again cause the equinus deformity. So there should not be heel in a CTV boot. But in this case there is CNE heel is given in CTEV. CTEV means what? CTEV in this case CTEV was there. CTEV means varus is there. In case of varus you can give CNE heel.
And there should not be confusion.
Yeah.
His confusion is genuine.
Yeah.
Because still some people, I don't know, in the CTV boot,
Yes.
they are still using crooked or elongated heel as reverse side. Right? So that is their confusion. So I think still that heel is in use in CTV. What do you say?
In CTEB boot it should not be there. So in CTEB actually there should not be heel. Heel should not be there.
So then where
It should be flat, completely flat.
then where to use it? How do we decide we have to use C and E?
No, in case of varus and valgus deformity of the ankle without
Usually now the prescription is to use a wedge in order to correct the varus.
varus and
The CNE is not commonly used.
not commonly used. So, no.
So that
Using wedge instead of heel.
Wait.
others, some people
For example, this one.
Yeah.
You can see here that we have given a wedge. The height of this has this side and this side they are different. So this is a kind of wedge which controls the varus.
Here you can see the weights. This is medial side. This is medial side. This is lateral side. So laterally the height is more, and the medially it is less. So this is wedge. So this type of wedge we give.
yes. Yes, in sitting again, please explain the middle bar and the T strap. The role of middle bar
Okay,
and
medial.
the T strap.
This is this is the medial side. This is lateral side. So if we put a bar here, I think we have one. No, I'll go with this one. Yeah, in this. You forget about this upper part. Up to here, you think about this only. This is AFO. From here to here, this is AFO. This is conventional type of AFO. We take calf bend, two uprights, and if we want to correct valgus or varus deformity, then you will give
Only one side. So
Yeah.
sitting only one bar, medial side, no lateral bar.
will give one strap, that is T strap. That is T strap strap here, and on the lateral side or medial side it will be.
On the lateral side, not
Yeah.
on the medial side.
Because T strap always works like this. Suppose this side is the
Okay, you
upright.
are talking about only
This side
CTV,
upside.
yeah, only CTV.
CTV, only CTV.
Whether
So,
varus deformity is there or
yeah,
it has
so
to be changed.
in the
Depending on the-
CTB,
Yeah.
this forefoot tendency to go middle side.
Yeah.
So T straps comes here, and then you attach with the bar. So that's always tendency to abduct the forefoot.
Yeah.
So that is role of T strap.
Okay. So this is KFO, knee ankle foot orthosis. This is the knee joint I told you earlier. This joint is drop lock knee joint. So this is when it is extended, then it will drop automatically and the joint is locked. Now you cannot fold it. But if you unlock, you have to flex it, you have to unlock it manually. After unlocking it, you can flex it. It is so tight now. So you can flex it like this.
Now, what is the point axis of those please explain. Axis is what is the point that needs to be
Normal anatomical axis of the knee joint.
What is that axis? You know?
Adductor tubercle.
Yes, at the level of tubercle.
सीधा नहीं होता है ना, पूरा टाइट हो गया, अटक गया. So
Okay.
it has KFO. It has two uprights, knee joints, one thigh bend, one cuff bend, and uprights are attached to the shoe width by the this thing. This is called stirrup. Here we have round stirrup which allows this type of movement. But these are not commonly used nowadays. Nowadays we use flat stirrup. The stirrup is flat, which is not mobile, usually which is fixed. And to allow ankle movement, we give ankle joints. Here there is no joint. In this patient there is no joint. To allow ankle movement, we give ankle joint, which can give full motion or limited motion. Usually we give limited motion, that is only dorsiflexion is allowed and plantar flexion beyond 90 degrees not allowed. Usually beyond 90 degrees not allowed, only dorsiflexion from that point, that is 90 degree from 90 degree dorsiflexion is allowed, not beyond. Flexion, plantar flexion beyond 90 degrees not allowed. That is, that type of ankle joint is given usually. Okay. And the shoes, this is conventional type of orthosis. Here we can give this shoe, we can modify according to the need of the patient. Whatever modification is needed, shoe raise, This is surgical shoe raise, wedging, anything which is wanted, which is needed according to the need of the patient, we can give in this type of shoe. Otherwise, to make it lightweight, we can accommodate a polypropylene type of AFO in this patient. In this type of KFO, we can add the polypropylene AFO here to make it lightweight. And the advantage of that polypropylene AFO is the patient can wear with any type of shoes. Here, the patient can only use this shoe. No other shoe can be used. But in case of polypropylene type of AFO, if we add to this, then that will help in, that will give the patient the choice to choose anything he can want, he can wear. Yeah.
That's right.
FRO.
This is FRO. FRO is what? Low reaction orthosis. That means it will provide what is the principle?
There is a slight minus 15 degree
Yeah. So little bit of plantar flexion is given at the ankle joint. Sometimes in polio patients, what happens? Some polio patients come, quadriceps are weak, but they walk freely without any help, any aid. They walk with a equinus deformity at the ankle. But if we correct that equinus deformity, he will collapse. He will not be able to walk. That principle is applied here.
Yeah.
Here,
Foot drop is great.
What a
Foot drop is we have.
Just sir.
contraindication is if there is any flexion deformity at the knee joint, it will not work. So you should not give. Recurvatum में थोड़ा सा problem है. Recurvatum it can aggravate the condition. In flexion में it will not work. Definitely, if there is flexion deformity at the knee joint, you will not give.
Basically, knee should be extendable. You should be able to lock the knee.
Lock the knee.
The purpose of this is to lock the knee by putting foot in a plantar flexion. As you are touching, it's getting hyperextended.
Yeah, the thing is
The
that
knee
when
cover
you
is usually should be around grade 3.
Yes.
And the hip extensors also should be
So
more than 3.
another mechanism in polio used to
Grade
be
3. Emerging grade.
external pressure.
Knee extension power should be around 3 at least.
Okay. Knee
2 plus 2, 3.
Can we
And the
use
hip extensor should be 3
can
plus
we use it
for
here
the FROs to
apart from
the
polio
principle
in any
of
other
FRO.
condition?
perform
Apart from polio, can we use it in any other
other condition you can
Any condition that causes weakness.
weakness. The
Weakness of
only thing
quadriceps.
is, only thing is the in case of this and also in other weight bearing orthosis. This will provide thrust posterior thrust. And in the weight bearing calipers like PTB orthosis, IWR orthosis, weight bearing orthosis, you should check the sensory integrity of the leg. That is the main point.
Do you have some foot drop experience, sir?
Yeah. Foot drop means AFO except weird and
If there is an orthosis with PTB socket,
yeah.
it is a ankle foot orthosis or it's a knee ankle foot orthosis?
PTB socket. That means that is not AFO. That is
It
not
is
actually an
wide
AFO.
living type of thing.
Yeah, that is an AFO, but it is called weight relieving AFO or PTB orthosis. That is called PTB orthosis. It is not KFO. For KFO, I told you that the name given is according to the part it encompasses. Joint, specifically saying the joint. If you are giving a PTB socket, orthosis with a PTB socket, that means it is up to the knee joint, not covering the knee joint. It will not cover the knee joint.
It can condense, it can...
No, it will cover, but it will be covered, but it will not get any support to the knee joint. So it will not be a knee orthosis. So knee will not come in the name of that, in giving the name of that orthosis.
AFO.
That is what I am telling.
Ankle foot orthosis. It is an ankle foot orthosis. It is a
But it is
type
giving,
of-
it is giving support to the knee.
No, it is not giving support. It is a patellar part. It has a patellar part in order to give the force. That's it.
Force to the knee.
Yeah. Just below the knee, not to the knee joint. That's it.
To push it backward. That means to give a posteriorly directed force at the knee joint so that it is locked. It becomes locked while bearing the weight. That's all.
Basically, आपका
To prevent collapse of the knee.
ground reaction force है. So during the initial contact, the ground reaction force will be at the heel. This basically, now the down reaction force, you are shifting it anteriorly. And the down reaction force will automatically be in front of the knee. That's it. This basically, it helps in preventing the hyperextension. That's it. It doesn't serve any other purpose. It holds it so that it does not lead to hyperextension.
So now this
It may, no? It causes, it prevents
flexion,
flexion is
buckling. तो knee जो फड़ों का क्या है?
So now we'll discuss the certain important spinal
excessive
braces.
ना हो जाए, मेरी recurrent जैसा ना हो जाए, उसके लिए वो pattern.
So what is this? This is Taylor's brace. What are the parts? This is pelvic band
with two upright.
With two uprights. Yeah. Shoulder strap. Okay.
So it is called long Taylor, right?
So ये कहाँ पे होता है? Where it is? It is
In between the iliac blade and
iliac
crest and the blade.
Yeah. So okay.
Advantage and disadvantage of this brace.
Indication. Ideally, what is the indication? Where it should be used?
Yeah.
Indications when you have to prevent any form of mobility from around D6 level.
D6 to
D6 to, this can go till the L4, L5 level also. When you use the ash brace, it is usually D6
suppose
to
there is a
L2.
fracture at L1 now.
Huh?
Suppose there is a fracture at
Yes.
L2, then
The fracture of L2, it's better to go for a type of this kind of orthosis.
This is
Lumbar orthosis. You not go extensively and prevent motion at the...
for L1,
For L1, you can go either for a Taylor's brace or you can go even for ash brace. But ash brace will work only when the collapse is less than 50%. If it is more than 50%, the instability is more, then it is better to go for a better rigid kind of orthosis. Either you can make a plastic kind of orthosis like an AP shell type of orthosis, or you can make a Taylor's brace.
what is gold weight brace?
So,
Gold weight
gold width.
is used for lumbar
There are different kinds of braces.
Yeah.
Lots. It's big.
Doesn't matter.
So
Because our book says so, that's why I think we cannot apply.
Gold width is for? I don't know.
For lumbosacral.
Now there is sort of time, so we'll just discuss the important points. Yes. Now, what the Taylor's brace, you must know, indication has told, now advantage and the limitations. Advantage, what are the advantages? It is easily made, cheaper, okay? And what are the limitations?